Assalamu alaikum. The clinical day. We have Mr. Hamid, 65 years, complaining of abnormal gait and recurrent falls for the last 6 weeks. He is known case of hypertension on amlodipine 10 milligram. For your kind care, you are the senior house officer of neurology clinic. You asked to discuss this issue with Mr. Ahmed, his son. Okay, I will set the timer, then you can start. Here you go.
Okay. Hello. My name is Dr. Mahmoud. I'm one of the doctor here in the clinic. Are you the son of Mr. Hamid, 65 years old?
Yes, I am, doctor.
Yes, and your name is Ahmed, right?
Yes.
Hi, Ahmed. I'm here today to discuss with you about your father's condition. And I might ask you if I will be able to examine him. And I will address all your concerns and get the and help him with that. Okay.
Okay, doctor.
Okay. So I can see from the notes that your father recently complaining of abnormal gait and has a recurrent fall. Is that right?
Yes, doctor. You're right, doctor. I was with him. I am the one taking care of him, and also I am the next of kin.
Yes.
Yeah, I noticed this happened for the last 2 months. It's started gradually, and it's progressive. Day after day, I feel his condition is not good, doctor. He's not feeling well, and I feel worried about him.
I really appreciate your concern, and I want to assure you that we will get the bottom of this. You're saying that he has a progressive fall balance. You mean that there is when he was this started suddenly or gradually?
Yeah, it was gradual, doctor. When I noticed him, he like drank and the one, and I try to support him, and also I bought for him a stick, but still he's not okay, doctor. I feel he's not taking care of him and of himself, and he is always falling, even with the stick.
Even with stick, so the stick is not helping him to make him more in balance.
No.
And you told me he has a fall. How many times he has this fall?
Almost now 3 times.
And did he hit his head at any time when he had this fall?
Yeah, one time he hit his head, but we went to the emergency and they did for him scan, and nothing was there.
Okay, that's good. Okay, and when he has this, he has this imbalance. It's all the time of the day or specific time?
No particular time, doctor. Most of the time.
And when he start walking, or in the middle, or at the end, or since he started?
No, since he's standing, doctor.
Since he's standing, and before he has this, before standing and walking, he doesn't have any. He's feeling any dizzy or any faint?
No dizzy, but not dizziness, doctor. But whenever he stand, he felt unbalanced.
Unbalanced. Okay. And have you noticed any change, any weakness in his arms or feet?
No, doctor.
Any change in his speech?
No.
Any change in his vision recently?
No, but he is wearing glasses, and he has some change in his back of the eyes due to his hypertension.
Okay. And have you noticed that he's dumping in the side while he's walking?
No.
Okay. And you said that he has high blood pressure, right? Does he has any other medical condition I should be aware about it?
No, only hypertension, and he's taking medication called amlodipine.
And this medication is newly started for him?
No, since 3 years now.
Any change in the dose?
No.
Okay, and he's taking any other medication apart from amlodipine?
No, doctor, but recently the GP, when he has these falls, he prescribed for him some vitamins.
Vitamins. Do you know the name of these vitamins?
I guess it's Mixavit, something like that.
Okay. And and have you noticed also any change in the weight of your father recently?
No,
Any recent fever?
no.
Okay. And have you any change in bowel habits?
Uh, he always has hard stool, doctor.
Hmm.
I guess this is for a long time, but we didn't seek advice for that.
This is for a long time.
Mhm.
Okay. And have you noticed any shortness of breath?
No,
Any heart racing?
no,
And he complain of anything before when he start to stand and walk? Does he's complaining of anything? Any heart racing?
no,
Okay. And you told me no change in his speech, right?
no,
Have you noticed any cheeky movement in his hand?
no.
Okay. I just want to ask, what do your father do for a living?
Uh, he was working as a plumber,
Hmm?
but now he's retired and staying at home.
Staying at home. Okay. And he who he live with?
Yeah, I am the one living with him, and
Sorry,
I'm
I
the one, yes, supporting him.
and before having this fall and imbalance in his gait, was he completely dependent on himself?
Yes, doctor, he was okay, and he was able to walk alone and to do everything of his activities alone.
Okay. And okay. And does your father smoke?
Yes, doctor, he's smoking around 5 to 10 cigarettes per day for last 2 years.
And okay, so I advise your father to quit smoking. We can help him with that because this will affect his blood pressure. So I can refer him to the smoking cessation clinic. They can give him medication to decrease the craving for smoking.
Okay, doctor.
Be happy with that. And what about alcohol?
Yeah, he is always drinking alcohol.
So he's drinking alcohol how many units per week?
You can guess, doctor, 14 units.
He's taking 14.
Yes, and mostly at the weekend, at the weekend, some of his friends coming and
Okay. Yes, I can see that. But I want also to, that the recommended units per week is 14 units, and you're saying that your father is taking more over the weekend, so
Mhm.
can help him with that. And have you noticed
Okay.
he has increased his alcohol intake related also to this change in his weight?
No, no, no.
Weight
It's almost the same.
almost.
Yeah, since long time.
Okay. And no change. Okay. And have you for any you told me no recent change in the weight.
No,
Any have you further any noticed any lumps or bumps in his body?
no,
Any vomiting or
no, no,
no? Any headache?
no, doctor.
Okay. Any family history of note of the same
Uh,
condition?
I can remember my grandfather was having stroke.
Hmm? And
Uh, yeah, at his 70s.
hmm, okay,
And yes, that's it.
that's it. Okay, and okay, and okay, you told me, is your father taking any over-the-counter medication or any?
No, no, never, doctor.
Okay, okay. So I would like to examine your father now, and I might
Sure.
ask him some question while examining him.
Mm-hmm.
Okay, first of all, I need to check the vitals,
Yes, blood pressure 150 over 100.
and I want also to check the blood pressure, the postural blood pressure line. Then
Excellent. Okay, no, the same or no change.
no change. Okay. So I would like also to do neurological examination. First, I would like to check the hand for any tremors or
No,
resting tremors.
perfect. No tremors.
Sometimes, okay. And then I will check, I want to check the power and tone
Yeah, the power is good, peripherally and distally, almost same.
and the tone.
The tone also normal tone, no change. or no significant change.
And the reflexes?
Yes, preserved reflex, triceps, biceps, and brachioradialis.
And the finger to nose test and other coordination?
Yes, nothing affected.
Nothing affected. And now I would like also to examine the sensation in 4 modalities.
Yes, all sensation modalities are intact.
Okay. So I would like to examine, I want him to check the gait while walking, any specific gait.
Yeah, he has ataxic gait.
Ataxic gait, okay.
Yes, you told me about pass pointing?
Yes.
Yeah, there is, yes, pass pointing positive.
Pass pointing, okay, and ataxic gait.
Yeah,
I would
yes.
like also to check the eye for the cranial nerves. First, I would like to check the eye for nystagmus.
Yeah, there's nystagmus positive.
Nystagmus positive. Okay, and I would like to check the visual field.
No affection.
No affection. I would like to any change in the speech tone.
No, you can hear him, but there's some dysarthria.
This eyes. Okay, and I would like to have a quick listen to the chest.
Yeah.
Any
No, nothing. Nothing. Equal air entry, no added sound, no wheezes, no ronchi.
Okay.
No crackles.
Okay, and I would like to check the lower limb quickly for the tone and power.
Yes, tone and power reflexes are normal in the legs, as well as the coordination. If you ask for coordination,
Yes,
or you didn't, yes, preserved.
the coordination is preserved in the lower limb. Okay, so it's only affected in the upper limb. Okay, so okay, and the sensation is normal.
All sensation modalities are normal.
And the Romberg test, when I was examining him while standing, Romberg positive or negative?
Negative. He can't. Sorry, positive sense without closing his eyes, I mean.
Positive, okay. Okay, so okay, Mr. Ahmed, after examining your father, what is your main concern?
Yeah, what he has, doctor? Is he having Alzheimer?
Alzheimer. Why you are thinking about the Alzheimer?
Because some of my friends' father having Alzheimer, so I guess my father, I mean, has Alzheimer disease, because this disease almost in the elderly persons. So I suspected that. I don't know, doctor.
And have you noticed any change in his memory recently?
Yeah, perfect, excellent. No, doctor, but nothing affect in his memory. He's fine.
Okay, so I will address your concern, but let me ask you some questions. Will tell you at the end. So, have you noticed any change in the bowel habits and the urine control of your father?
Yeah, doctor. I noticed recently, doctor, he couldn't control his water work anymore. He always wet himself.
And this also started in the last 2 months.
Yeah.
Okay. And what about the bowel? Is he able to control from his back passage?
Yes, because of hard, so he is controlling it.
Okay. Okay. So after examining your
2
father,
minutes left.
okay, after examining your father, I think we need to admit him and to run for him some investigation, because he might have a condition that is affecting his balance, and this could be due to aging. So we need to admit him, to run for him some investigation. I will include a group of doctor, including the specialized doctor in the nerves, and also as a geriatrics, the old doctors, and to check, to examine him. And also I would like to do for him an imaging for his brain and run for him some blood test, because he might have a condition that is affecting his the balance, and his gait. How's that sound?
Okay, doctor, but what's this condition? Can you name it for me? I want to Google it.
Okay, so your father might have a condition that affecting the cerebellum, which is part in the back of his brain, and causing for him I have many differential. One of them, it could be a condition called normal pressure hydrocephalus, that it affect his brain, and also I need also to exclude the other condition from aging affecting the brain. So there's many things that run in my mind, so I need to.
Okay, doctor.
Okay.
Time is up almost. Yes, time is up now.
Yes.
Present your case, examiner time.
So I examined this gentleman who's presented with recurrent fall and imbalance. He has a past medical history of high blood pressure and amlodipine. And also he has also difficulty in on controlling his urine. So on examination, he was having examining his neurological, he was having ataxic gait, positive Romberg, with poor coordination was impaired. He was having nystagmus in the eye and dysarthria. Putting this all together, this, and also he has a history of alcohol intake with smoking. He might have conditions that affecting the cerebellum, and could be due to alcohol, his alcohol intake, and it also due to aging.
Okay, name for me three conditions or three diseases can be differential for this patient.
For the cerebellar, it could be cerebellar syndrome. You mean the disease itself?
Yeah, so cerebellar syndrome due to what?
Cerebellar syndrome due to alcoholism.
Okay.
It could be due to a paraneoplastic.
Excellent.
It could be, and also because he's smoking, it could be also paraneoplastic, yes. Alcoholism and paraneoplastic. It could be a post-cerebellar stroke. A posterior, it could be a cerebellar stroke in posterior fossa stroke, and also it could be inflammatory, as in an infection.
And on the top of your differential, what you name for the son?
I told him normal pressure hydrocephalus.
Okay, what's the evidence for normal pressure hydrocephalus in this patient?
Normal pressure hydrocephalus, the patient will have ataxic gait,
Okay,
urine incontinence, and we'll have, I think, a memory disturbance. I'm not quite sure.
cognitive dysfunction. Cognitive, yeah.
Yes, cognitive dysfunction.
Okay.
Yes.
Yes, that's enough. How to investigate this patient?
Yes, for this patient, first I would like to do for him a CT scan to exclude hemorrhage and a stroke, and also I would like to do an MRI to check the cerebellum, MRI scan. I would like to do for him a full blood count, and also we need to check for the alcohol intake by doing this SIWA questionnaire and checking if he has tremors, if he has sweating, for excessive alcohol intake, and to check for to do full blood count, inflammatory marker, renal function, and liver function, and vitamin B12. This is it.
Okay. Regarding the CT, what do you expect in the CT?
CT for if it's normal pressure hydrocephalus, atrophic changes and widening of the sulci.
The ventricles.
Ventricles, yes. Okay.
Yeah.
The ventricles, yes.
Okay. How to manage this patient?
I think for this patient, we need to include the multidisciplinary. I believe for this patient, we need to include the multidisciplinary team, including the geriatric team and neurology team, occupational therapist, and physiotherapist. um, after we can give him medication for the if he has dementia. I think no specific treatment if it's normal pressure hydrocephalus.
Okay, so what are the team involved in this patient management?
The neurology, the geriatric, the occupational therapist,
Okay.
The social service, and the physiotherapist.
Yes, excellent. So the most important occupational therapist. Okay. You told me no specific pharmacological therapy, right?
But we can give treatment for the dementia as mentadine and
No, it's not.
okay.
Okay. If you find dilated ventricles, is there any chance to treat this?
Dilated ventricle?
Yes, normal pressure hydrocephalus.
No, I don't know. Yes, yes, we can make lumbar puncture and also ventriculoperitoneal shunt.
Excellent. So either recurrent puncture or ventricular, yes, ventriculoperitoneal shunting, VP shunt. Yeah, excellent. Well done, Dr. Sarah. This is the case. I guess the time is up. Yeah.
Yes. Okay. I think I don't know. I don't have self-confidence.
No.
Forget it. I think I forget.
No problem. Just to start a systematic way,
Yes.
and my advice, put differential before starting. So in elderly, we mentioned in the session, if you attend, I think you didn't attend this session. We did the session for neurology and endocrine. And we mentioned some of the geriatric disease and CNS in the old age. This case scenario is coming as normal pressure hydrocephalus. And there is triad. You already discovered most of the finding. Apart from dementia, you should ask me about his dementia and his cognitive function. But you remember at the end only to ask about the memory. You could ask about also sleep and stress and his awareness and I mean yes his cognitive function in the environment and in the life. I could tell you yes he's not okay nowadays and he's not you asked me about the memory, but it's not only the memory, even for the confusion. Yes. Apart from this, you cover the question for normal pressure hydrocephalus. Apart from the urinary incontinence, which you remember when I ask you, is it Alzheimer? Then you remember the normal pressure hydrocephalus. Anyway, it's better than nothing. The CNS as analysis, you cover all the question, the weakness, but the sensation you couldn't ask or you didn't ask about any sensation friction. You should ask also about it. However, it's not the case. The vision, you ask me, yes, and during examination, you did examination for the nystagmus, but you didn't offer fundoscopy for retinopathy, which is
yes, the patient was having this hypertension.
Yes. Then the other constitutional symptom, yes, you have to ask to rule out paraneoplastic. It's one of the most important since he's a smoker for a long time, and it might come as cerebellar syndrome. Stroke or mini stroke, you can ask specific question like he had any history of stroke, or as you said, is there any neurological deficit or anything affected his weakness or sensation? This is for stroke syndrome or cerebellar syndrome as cerebellar stroke, I mean. I guess this is the most important question for the CNS. The other system, as you ask, quick review, chest pain, awareness of heartbeat, because of two risk now, he's smoker and he is hypertensive, he might have any heart attack, and you can specify a question for heart attack, any heart attack. It's important in such age. Short of breath, yes, you can suspect lung cancer, however, he doesn't have. So it's pure neurological case. Abdominal pain or tummy pain, any change in his bowel habit, and any change in the water work. And I could tell you he has lost the control of the water work recently. and you can by this catch the case. Skin rash or joint pain, yes, he might have osteoarthritis as elderly, but you have to ask. Don't miss any system as a quick review. Only one question for each system, okay? Try to train yourself from now onward to ask one question in system review. It might give you a clue, or it might give you to give the examiner the expression that you are understanding what's going on and you are not leaving or not skipping any system. It's very important. I guess you can see the comments. They are commenting about small things like that. Okay.
Yes.
Yeah, I mean, for me, he commented on abdominal pain. However, I asked for gastropathy finding, but he wrote for me he didn't ask about abdominal pain, and the case was Charcot joint. I don't know what's the relation, but they put it in the agenda. He didn't ask about abdominal pain. Anyway, so try not to miss any system. Maybe one question or one system with one symptoms, it might affect the mark. Okay.
Yes. Yes.
Yeah, the medication history, you ask about all, but you didn't ask about surgery or
Yes.
allergy. Also, try to make it a scheme to ask all these questions whenever you have history taking patient, okay? Finally, the case, as you said, the examination, you cover all the gait, the pathognomonic here, the finding also the neurological examination. Apart from fundoscopy, you have to offer it. However, they are not offering fundoscopy nowadays, unless they will bring a case of retinitis pigmentosa. Other than this, for the last 3 days, we didn't see any.
Or sometimes they are bringing a case of laser photocoagulation.
But they are not bringing a fundoscopy.
No,
I never.
for two things: retinitis pigmentosa and laser photocoagulation. They both cases like this.
Yeah, but again, I didn't listen or hear about offering fundoscopy, and they offer him the fundoscopy for the last 3 days. I mean, after the new format. I don't know. Maybe they will provide it in the next diets. I don't know. But anyway, offer it just to be aware about the change in the retina, either diabetic or hypertensive, or even the disease related like retinitis pigmentosa. It will be diagnostic one or diagnostic tool. I mean,
Okay.
okay. Apart from this, you did well.
Okay.
You have any question? Most welcome.
Yes,
Your differential also were good. About alcoholism, yes, it might be due to his alcohol intake, cerebellar syndrome due to stroke, and paraneoplastic. And before all this, the case will be normal patient hydrocephalus. The evidence you have the cognitive dysfunction, ataxic gait, and the last is urinary incontinence.
And the
Okay.
patient is lumbar puncture and also
Yeah, this is the definite treatment.
Mm.
Yeah, it could improve the finding and the symptoms
Mm.
apart from the walking disability. It takes time.
Thanks.
Okay, you have any question?
Oh, thank you so much.
Okay, let's read the comment. Any question from any comment? Dr. Rabia, you are here?
Yes, Basim, I'm here.
Yes, please give us the neurology point of view from your side.
It is a case of normal pressure hydrocephalus, right?
Yes.
You said finger nose ataxia positive or negative? You said
Sorry?
that, right?
Ataxia?
Finger nose ataxia was negative or positive?
The ataxia, yes, positive.
The finger nose.
Yeah, is it positive? I said positive, yes.
Yeah,
Is
it's
it...
not going to be positive, Dr. Basim, okay? Because it's not cerebellar, right? It's normal pressure hydrocephalus. And
Only
he's just going
ataxic
to
gait.
have, yeah, and it's going to be like a magnetic ataxic gait, you know? He will feel that his feet are just glued to the ground. He is going to be a magnetic gait, okay? So ataxic gait only, nothing to be have finger nose ataxia. Because if you're going to have finger nose ataxia on nystagmus or dysmetria, that means you are affecting the cerebellar vermis, cerebellar lobes. It's nothing to do with the cerebellum, okay?
So ataxic gait without cerebellar affection.
Yes, yes, absolutely.
Mm-hmm.
Okay, and how to see the effect? Once you do the lumbar puncture, you actually check for the immediate walking. So within 30 minutes of doing the lumbar puncture, the walking improves.
So the walking is improving first. I said this is the last to improve. So it's improving after immediately. Yes. Okay.
Yes. And that is why you send the patient and you think there's improvement. So you send the patient for VP shunting. Okay.
Yes.
That means he's responding and this patient will go for VP shunting.
So it has only sensory ataxia, not cerebellar ataxia, right?
No, not
It's going
sensory.
to-
It's
No, it's not
ataxic
going to be
gait,
sensory.
not related to cerebellar, and they're
Yes.
not related to the sensation.
Yes.
Ah.
It's just going to be because his pressure is normal pressure hydrocephalus, but his ventricle are enlarged and the CSF is increased. Okay. So he's have difficulty in just walking. It's not going to be dorsal column. It's not going to be cerebellar. You feel
And
that
no mechanism in Dr. Rabia for that. You mean it's
no. He's just, it's called magnetic gait. His feet are glued to the ground. That's why he feels ataxia. He will feel that he is broad-based and he's having a what you call a glue gait, magnetic gait.
And when we explain to the patient, we say there is no cause, it's unknown cause. Not
Yes, there is no cause. It's idiopathic, okay? There is no cause. Yeah.
And so Romberg test will also be negative.
Will be no.
yeah.
Yes, Rombergs will be negative. Yes, he's going to be ataxic while standing, so there's no need to do Rombergs. Rombergs is for dorsal column, okay?
But Romberg will negative. It's not positive.
No. It will be negative. I'm saying that patient is already standing and he will be glued. Tamam. When you ask him to walk, he will be ataxic. While standing, there is no ataxia. Okay?
And why this ataxia? This is my question also. Why ataxia for what reason? It's nothing related to the balance, right?
No, it's nothing related to the. It's just that the ventricles are enlarged, okay, and it's compressing the cortex. There is atrophy along with the ventricles enlargement. Okay, so actually the connection of the fibers is what you call is derangement. Okay, so he's not getting the signal that he wants to walk. So the feet gets glued to the ground. It's due to the increased size of the ventricles. Okay, there's no link of the cerebellum. Okay, or the dorsal column with that. So all the signs will be negative of ataxia except only the gait.
Okay, perfect.
Thank you so much.
Anything else, Dr. Rabia?
No, nothing else. Thank you.
Okay, thank you too for the clarification. We now got the gait is not related to the cerebellum, and nothing will be positive in the cerebellar.
Yes. Okay. Good.
Finding, yes.
And why was he having constipation, Dr. Vasan? Because of what, Yani?
No, it's nothing. Sometimes the constipation is like usual habit. It's not something. It's not related to the case.
Right. Okay. I was thinking it's Parkinson. That's why he was having some non-motor symptoms.
No. I deny any tremors or the rigidity.
Okay. Right.
I put it as most of the elderly having constipation.
Yes.
It's not related to the case. Yes.
Okay. Fine. Got it.
Okay. Any question from others?
Dr. Bassem, any link between constipation and confusion apart from this case, away from this case?
Yes, sometimes if you don't have any reason, you can say the constipation maybe in the elderly can lead to a confusion, acute confusional state. Yes, you're right.
Yes,
but if you don't find any organic cause, but in this patient you have organic cause.
Yes. I think we should put also the multiple system atrophy, especially we have cerebellar signs.
Yeah, that's why Parkinson plus syndrome is one of the differentials of this type of patient.
And also I know from before that normal pressure hydrocephalus, you should find dementia.
Yeah, it was there, but Dr. Sarah didn't screen about it. Yeah. But why multi-system atrophy if no postural hypotension?
Just in differential diagnosis because there is cerebellar signs. That's what I mean.
Cerebellar signs, we said no.
No cerebellum.
Yeah,
No,
it's only
exactly.
attacks the gate. Again, this is this was the point of confusion. Attacks the gate without cerebellar. Yes, I put
Okay,
it, but
okay.
assuming
Doctor,
that there is cerebellar, as all of you suspect also.
this is very good clarification from Dr. Rabia.
Yes.
But
Yes, of
the
course. Yeah.
presentation was ataxic gate positive past pointing
Yes.
and positive
Yeah.
nystagmus. So this is cerebellar signs all.
Yeah, if you can put here, if the case like this, you can put cerebellar syndrome related to stroke or Parkinson plus, as you said.
Yes.
Yes,
Yes.
yes.
But as the case is normal pressure hydrocephalus, so Dr. Rabia clarified the thing. It's not a cerebellar syndrome or not cerebellar symptoms. So the normal pressure hydrocephalus ataxic gait is not related to cerebellar. But
Yes, yes.
if we face a case like this, you can put cerebellar
Yes,
as a
absolutely.
differential. Yeah.
Yes. This is what I'm trying to say. This is PACES exam, okay? They don't know
Yeah.
the pathology too much. So differential of Dr. Sara was very good. It could be cerebellar syndrome, secondary to paraneoplastic, secondary to stroke, secondary to
Yes.
alcohol. It could be normal pressure hydrocephalus. It could be Parkinson plus. You can put all the three differential in this patient.
Yes. And always this discussion make the things more clear. So please share us the ideas.
Thank you, Dr. Rabia.
Okay, one
Yeah.
idea also. I
Yes.
think you, doctor, you should ask about hallucination and cognition also.
Yes, yes, yes. I should.
Also the gaze palsy for progressive supranuclear palsy.
Okay, if you suspect Parkinson plus, still all these points are valid, yes, as differential of tremors and Parkinson's syndrome,
Yes.
like Lewy body dementia.
But I think if the patient have rigidity, resting tremors, any sign of Parkinson, so we can add all the Parkinson plus.
Yeah, whenever you have, we did the last week Parkinson plus.
Lewy body dementia, so we can, but the patient doesn't have.
Yes, you're
he
right.
has cerebellar only. He doesn't have any Parkinson, any tremor.
That's why my advice, whenever you have the complaint, put differential and screen the differential before starting system review. Because your differential will be in the answer in the differential, and also you can find the diagnosis from your differential. But if you start system review without putting differential and rolling out the causes, you put it as in the differential, you will be in trouble. That's why also I am doing neurology. Since I started neurology, I'm trying to make the all neurology cases together. I mean, session after session. We did the headache and we did tremor for Parkinson. We did weakness, and now we are doing also geriatric condition. I'm trying to focus on one system to cover all the cases might come in this scenario or in this branch. Then I will skip to the next system. I hope it will be beneficial for all of us.
Yes.
And yes, just to know what's coming in the exam and how to do and how to deal with. So the tremors, as Dr. Ahmed said, if you have any tremors, you have to roll out Parkinson and Parkinson plus. Since you rolled it out, you can go through the other differential like paraneoplastic, cerebellar, if he has any cerebellar finding. And in our condition here, normal pressure hydrocephalus, you can suspect the alcohol or vitamin deficiencies even. You can ask about diet, Dr. Sarah, any dietary limitation or...
That's right.
Yeah, because some patients with subacute combined will present with cerebellar. Again, if he has cerebellar, but the cerebellar in this scenario was like out of the differentials. Okay. And Dr. Rabia also clarified the things about the finding, and the walking disability here was related to... It wasn't related to the cerebellar. It's something related to the cause itself. Any question? Yes, Dr. Azhar, sure.
Since we are doing this neurology, I just want to add something about multidisciplinary team. If examiner asks what will be the component of the multidisciplinary teams in neurology case, in every neurology case, we can put PONS, PONS, P, physiotherapist, O, occupational therapist, and neurologist, S, specialist nurse.
Yes, bones. البونز.
P O N S. P U
Yeah, the
N S.
bone. The bones.
Bones.
And the brain stem, yeah. Okay.
We can put in every,
Yes,
and then
yes, you're
according to
right.
situation, we can add in motor neuron disease is following problem. We can add salt.
Yeah, you're right.
Yes.
Okay. Encephalopathy, chronic liver disease. Yeah, if chronic liver disease, definitely will have finding of encephalopathy and the other stigmata of chronic liver disease, starting from jaundice or tremors, or also the skin finding of chronic liver disease. But it's not the case here. Also, from outside, think of GCA, since the recurrent falls might simply proximal myopathy. Yes, Dr. Rhoda, you're right. Again, if you find these things, and the complaint will be different, by the way. It will be either weakness or difficult to stand from sitting. But GCA will present with headache and eye or scalp pain or vision problem. Okay. The neurological examination should be normal except gait. Yes, you're right. Gait looks like Parkinson, exactly, but it's not ataxic. Or Parkinson, you mean the shuffling, slow shuffling gait? Yes. Dr. Rabia said glow-like. He's
Magnetic.
magnetic, yes. So it's like also the Parkinson, slow and shuffling, right? We can.
No. It will not be slow and shuffling. He will walk with the legs opened, and it will be like that the foot is glued to the ground, He will not be able to
Okay.
take steps quickly.
Yeah. Okay. So the best thing is to find a video in the YouTube showing these steps. If someone can do it, it will be more and much beneficial. Yeah, glue-like, yes. Glue-footed. Really, first time to hear this stepwise. Anyway, we will try to find it in the YouTube and to share it to all to be more aware. The next scenario, 35 years old Jannat Henderson complain of dizziness. Okay, good. Ready, Dr. Sarah? Let's start.
Wait, you don't want to have 2 minutes?
It's okay. I'm trying to collect some of my thoughts, then I will start. Just give me 30 seconds.
Okay.
And anyone has comment, he can write it
Okay.
before starting. Okay, Dr. Sarah, let's start.
Okay.
Hello there. I'm Dr. Mukhtar, the doctor in the clinic today. You must be Mrs. Jannat
Yes,
Henderson.
Doctor. Yes, I'm Janet. Yes.
You are 35 years.
Yes.
How can I call you today?
Janet.
Janet, okay.
Yes.
We are here to discuss about your health issue. That okay for you?
Yes, please, doctor.
Yeah, can you tell me more about your complaint?
Yes, doctor. I started. I'm not feeling okay for 2 months ago. I started to feel dizzy, and this is affecting me a lot, and this is start to be more frequent, especially now we know we are in the summer. I don't know this summer is too hot this year or no. I'm trying to relate what's happening with me, but I don't know exactly what's happening. I'm feeling dizzy and faint.
Okay, I'm so sorry to hear about that, Janet. Can you tell me more about this event? How many times you had these attacks?
Yes, I was at first. It started to be. I was having 1 or twice a day, but now it's more frequent, all over the day. I'm feeling myself dizzy.
Okay, sorry again to hear about that. Can you tell me, is it in a particular position?
Not in particular the position, but I notice it's more when I'm trying to stand or sit.
Okay. So standing from sitting position make it worse.
I notice that it's become more.
More, yeah. Okay. And did you notice something related like while eating or doing
Yeah.
some activity, particular activity, I mean?
It's not activity. I'm feeling also when it's hot, I'm feeling myself dizzy. I don't know because the hot weather or this is something not related. I'm trying
Okay.
to say many things, but I don't know exactly what's happening with me.
Okay. And are you taking good water amount or?
I started to be careful of my drinking, and all the time now I'm walking with have a bottle of water with me.
And did it improve after that or the same?
I think it is the same, but
Not related.
sometimes when I'm drinking water and I'm not having it more frequently.
Okay. And did you lose your awareness at all?
No, I'm feeling myself about to faint, but I'm not fainting, and I'm feeling myself dizzy.
Yeah, so you see blackout?
Yes, not blackout. I'm feeling myself as dizzy. It means that I'm not concentrating something wrong, but I'm not fainting, and I'm not losing conscious, or I'm not feeling.
Okay.
Yes.
And you didn't fall at all?
No, I didn't fall.
Did you hit your head?
No, I didn't fall because I'm trying to sit when I'm starting to feel like that. I start quickly to sit down.
Okay. Did you notice it while standing for a long time?
Yes, it's more when I'm standing for a long period of time. It's become more also.
And is it related to stress?
Mm,
Did you notice?
maybe yes, maybe. Not quite sure of that, but maybe yes.
Okay. Did you feel your heart beats before the fainting or feeling dizzy?
Yeah, no, when I'm feeling dizzy, I'm feeling my heart beating also. Yes, you are right, doctor. I
You are
notice sometimes I'm feeling my heart is beating too fast.
too fast.
Yes.
It's not slow.
No.
Okay. And are you diagnosed with any condition before?
Yes, I have fibromyalgia, and I have also hypermobile joint, and I have also irritable bowel syndrome.
And are you taking any medication?
Not for the hypermobile joint. I'm not taking anything. The fibromyalgia, I'm doing some exercise, and I'm taking some supplement for it, and nothing for the inflammatory irritable bowel syndrome. Nothing.
Okay, I know what the name of medication you are taking for fibromyalgia?
I'm taking vitamin D,
Uh-huh.
and sometimes the doctor give me, I think, medication called amitriptyline, but I'm not taking this medication.
And since when you stopped it?
I'm not taking it. I didn't
You
take it.
didn't take it at all?
No.
Okay, and you notice this thing happen after some medication? I mean the
No.
dizziness?
No.
At all. Okay. Are you taking any over-counter medication?
No.
Any herbal remedies?
No.
Any surgery before?
No, I didn't do any surgery before.
You have any allergy to any medication?
No.
Sorry for this question. Are you taking any recreational drugs?
No.
Nothing. Okay. Apart from this, you have any headache?
No, I'm thinking. No, I don't have headache, but I'm thinking also I'm having as a brain fog. When I'm having this dizziness, I feel my brain like it's not working well. This also all of these symptoms I'm saying to you together happen to me.
Okay. And do you have any phobia?
No.
What about your mood?
My mood is good before having this, but I started to be more anxious now because I don't know what's happening with me.
Okay. And your sleep?
My sleep is good. I'm
Do you
trying
have
to good hygiene sleep in order to sleep well.
Okay, you have any stressful condition in your life?
No, because I since I have been diagnosed with fibromyalgia, I try to avoid stress, to have good sleep hygiene. I try as much as I can to avoid this because they told me this one of the can.
Okay, great. And for the medication prescribed for you, can I advise you not to take it temporary until we diagnose you, okay?
The vitamin D, you mean?
No, the tricycling and the antidepressants.
No, not.
Amitriptyline. Yeah, I know, but in case of, okay? That's
Okay.
good.
I won't take it. Okay, thank you.
Okay, any balance problem?
When I have this, I'm feeling myself, I have some imbalance. That's why I'm sitting quickly.
And any hearing problem?
No,
Okay, any pins and needles or weakness?
no,
Any difficult swallowing?
no.
Any intolerance to any weather?
Yes, I couldn't tolerate cold weather. I'm feeling all. Yeah, I'm not feeling cold. I'm wearing now. If you see, I'm wearing light clothes.
So you are preferring the cold weather?
I'm preferring the cold. Yes.
Yeah, you prefer the cold.
Yes.
Okay, and any awareness of your heartbeat?
I told you when I'm having this dizzy, I'm feeling my heart is racing.
And any chest pain?
No,
Any short of breath?
no,
Any change of your bowel habit?
no.
How about your water work?
Normal.
Normal, nothing change.
No,
Any skin rash?
no,
Any joint pain?
no,
Any family history of same condition?
no,
Any trouble recently you notice related to your condition?
no.
Okay, and sorry for this question. You have sensitive question. You have any change in your period or?
No, my period also I notice that I have the symptoms more frequent when I'm having my period.
Okay, but no change in the amount?
No change, nothing.
Okay, and you have any babies?
No, I'm not married.
You don't have a partner?
No, I'm not sexually active.
Okay, any problem for that?
No,
You have any casual relationships? Sorry for this question.
no. I'm not sexually active for 1 year.
Any? Okay, and you think you have any problem with this?
No,
Oh,
no,
nothing.
no,
You are not interested.
no. Yes.
Okay, do you smoke?
No, I'm not smoking.
Do you drink alcohol?
Yes, I'm drinking.
How many per week?
I'm drinking maybe more than 14 units. I know the recommended dose. I'm drinking too much this day because I started to be more anxious.
Yeah, but again, it's against your health and it might harm you.
Yeah.
So I advise you to reduce your
Okay.
alcohol intake, okay?
I'll try. Yes. Okay.
What's your job?
I'm work as an accountant.
Accountant. And this affecting your job?
Yes, it's affect me a lot, doctor. Yes.
Do you drive?
No, I'm not driving.
Okay. Any loss of weight recently?
No,
And how's your appetite?
my appetite is good.
And any lumps in front of your neck?
No,
Any lumps or bumps at all?
no,
Any night sweat?
no,
Body temperature? Rising body temperature?
no.
Okay, can I examine you?
Yes, please.
I will start by the general look. How does the patient look? Underweight or
Normal weight.
normal average weight? Okay, and vitals, please. Can you give me blood pressure, pulse rate, and temperature?
Pulse rate is 100, but otherwise everything is normal.
Okay, did you measure your blood sugar anytime?
No.
Can I offer for blood pressure? Sorry, blood sugar?
Normal.
Normal. I will examine here now about positional hypertension. I will do blood pressure sitting and standing, and the
Normal.
pulse as well.
Yes, the pulse is increasing while from sitting to stand.
So increased after standing. Okay. I will examine now a quick examination in the face. Any change in the eye, I mean pallor or jaundice,
No,
and any pigmentation in the mouth, any sores.
no.
Just remind me if 2 minutes left, okay?
Yes.
The neck, any thyroid swelling or any swelling at all?
No.
Okay, any raised GVP?
No.
I'll examine the pulse peripherally and both arms. Equality?
Regular and equal.
Equal, no delay, no radio-radial delay?
No.
No radio-femoral delay?
No.
No raised GVP, right?
No.
I will examine the heart S1 and S2.
Normal.
Normal. Any murmur?
No.
Nothing. I will auscultate the chest quickly at the back. Any crackles?
Nothing.
Nothing. Quick examination to the muscle of the arms. Any myopathy?
Nothing.
Any tender point?
No.
All over the body? I mean shoulder and
No, no.
girdle? Nothing. Abdominal examination for organomegaly? Any abdominal pain?
No.
Nothing.
Hmm.
Okay. In the legs, I will examine any joint problem.
She has hypermobile joints when you examine.
Yeah, so let's examine the wrist sign.
Yes, she had.
She has, and the thumb.
Yes.
Okay. Any high arched palate?
No.
The skin itself, elasticity?
Yes, skin cigarette areas increase elasticity. When you ask her to pinch her skin, it's elastic.
So much elastic. Okay. And nothing in the auscultation of the heart? No signs of
No.
any valve repair, regurg?
No.
Or prolapse?
No.
Okay, now I'll examine the leg for any edema.
Yes, nothing.
Nothing.
2 minutes.
Yes, 2.
Okay, may I know what's your concern?
I'm concerned, doctors, this is related to the fibromyalgia or the hypermobility that I have, and I want to know what exactly happening with me.
Yeah, I appreciate your concern, Mrs. Janet. I guess what you have is something called functional disorder. Don't bother about the name. It's a medical term we are using to diagnose certain conditions. Since you have fibromyalgia and irritable bowel syndrome, so related to this condition, there is a condition called Bushra orthostatic tachycardia syndrome. Don't bother about the name. And we can name it as POTS. This is abbreviation. This condition happened when you are trying to stand from sitting position and the heart reactively increasing in the pumping, and you might have this feeling of dizziness along with racing of your heartbeats. So to confirm this diagnosis, we have to run some blood tests and some scans and image to be sure about your condition and to rule out other possible conditions. How do you feel about that?
Okay, and this is a treatable condition, doctor?
Generally, I advise you to drink plenty of water, to be good hydrated, and to eat well, and to avoid standing for a long time, and avoid also the hot weathers, and avoid any stress and stressful life condition. Everything might be settled, however, it's not controllable one.
Okay.
You have any other condition, any other concern?
No, thank you, doctor.
Okay, again, related to the alcohol, I advise you not to drink alcohol, or sorry, to monitor and to reduce your alcohol intake. It might worse also the condition.
Okay. Okay.
Okay, any other concern?
No, thank you.
Time is up. Why I'm not telling about the time, okay?
Yes, it's up, but when you said alcohol,
You can tell me, I don't see the mobile. Okay, you can start now the question.
Okay, so present your case.
Yeah, Janet, she's the 35 years female, came with complaint of frequent attacks of dizziness, recently worsening in the background of fibromyalgia and irritable bowel syndrome, and she has also hypermobile joints. It might be I'm not sure about the diagnosis, but we can think about pseudoxanthoma elasticum, or it could be other condition. Apart from this, this dizziness happen especially when she's standing from sitting position, and nowadays the frequency increase, but she tried to correct her fluid state by drinking plenty of water. It improved little bit, but still the attacks is coming. She has also history of palpitation whenever she feel this dizziness, and in the examination, I couldn't find any significant signs apart from the tachycardia while standing when she stand from her sitting position. So collecting all this together, this patient has mostly a condition which is called POTS syndrome, postural orthostatic tachycardia syndrome, along with her background of fibromyalgia and irritable bowel syndrome.
Okay, and what investigation you will do for this patient?
Yeah, starting by the baseline basic investigation to rule out any anemia, and also electrolytes, full electrolytes. I mean, all to rule out any hyponatremia or any other electrolyte disturbance. Apart from this kidney function and liver function tests, vitamin screening, because she's also drinking a lot of alcohol, just to rule out any vitamin deficiencies, especially vitamin B12 or vitamin B6. Apart from this, no specific test, I mean blood test for this condition, but we can do health table test.
Yes.
Health table test for confirming the diagnosis. It's similar to vasovagal attack. However, instead of decreasing or heart rate or bradycardia, patient will have tachycardia in different, changing the position, I mean.
Okay, and you said the differential, what is the differential for this? Your differential?
Yeah, still we can put vasovagal attack in the differential. We can also think about alcohol related or vitamin deficiency. Yes, this is what came in my mind.
Okay, and what's the treatment?
Yes, it's mainly including the multidisciplinary team approach. I mean physiotherapy and social worker, neurologists, and rheumatologist for the hair original disease. And if she needs, we can call also psychologist for hair fibromyalgia, physiotherapy again, and limb physiotherapy again for the main condition. Apart from this, the main management will be non-pharmacological education and counseling about the disease and the complication, avoiding the exposure to the hot weather, avoiding standing for long time, avoiding also stress and any anxiety. It might exaggerate the condition.
Okay.
Apart from this, pharmacological therapy might be like vitamin supplementation, some vitamins, and yes, I guess nothing to be. And we can give her precaution about the alcohol intake, along with avoidance of tricyclic antidepressant. It might lead to some arrhythmias that might worsen the condition.
Okay, good. Okay. I don't have question. You still have 8 seconds, but I don't have question. You did it well.
Okay, thank you.
I didn't know that you will know the diagnosis, so that's good. Okay, so it's POTS.
Okay, so you give me the case as a challenge.
Because this case came and they are starting to bring case which you don't know.
Yeah.
POTS is one case that it's coming now. Okay, so she's this lady. You did it well. You got the diagnosis. You ask about everything, but you can ask about the diet because high carbohydrate diet can.
Yes.
Okay. So and when you explain for her, usually this called orthostatic intolerance. It's mean you will In lay language, you will say this is normal the nerve balance between the heart rate and the balance of your body, no matter position. But in your condition, the body is not the heart. Your nerves are not able to control
Yeah.
it when sitting or standing. So explain this for her. Okay, and so the part regarding this disease, let's revise it quickly. This patient might have, usually I saw one patient that she came to me, she was wearing, wasn't wearing any ties, and it was very cold. So I asked why she was having hypermobile joints. That's why I brought this case with us, and have inflammatory bowel disease and fibromyalgia. So I told her, why it's too cold, why you are not wearing ties? She told me, no, this because I have POTS. And so the POT patient couldn't tolerate being in hot place. Okay. And they will have tachycardia or fainting from standing or sitting, and eating high carbohydrate diet like bread and all this make it worse. Alcohol, exercise, and having the period and stress, as you said. So you was right in all of those things, and not drink too much water. Okay, and usually it could be associated with fibromyalgia and as this patient. And the patient also may have also may say that I'm feeling sick, I'm having diarrhea. Maybe some patient may have this, some can have headache. But the main pathognomonic thing that you will find the heart, the tachycardia, okay? And you will have some vein fog also. Okay, for the treatment is the diagnosis, as you said, the tilt-table test. This is the only diagnosis, and you will do the normal diagnosis for differential, for the anemia and all the things. You did it well, okay. And the treatment is the lifestyle, have small, frequent meal, low refined carbohydrate, and also when they have this fainting, they can clench the fist and clench the muscles of the tummy, and also they can cross the leg with one leg standing on the other. All of this can help to decrease. If she's not able to sit when she feel faint, she can do all these things. Okay, clench the fist or put crossing the leg. All this will decrease the fainting and the feeling. And also she can have there is some medication, she can have isotonic tablet. This patient was taking isotonic tablet, and she was taking also salty diet. And you can give some medication. There is some medication you can give.
Hydrocortisone.
Yes, hydrocortisone. You can give midodrine for the hypotension. Yes. And some beta blocker can decrease the tachycardia. But it's the medication, it's mainly lifestyle, but you can add. Yes. Okay. So this is the treatment for the POTS. And this patient also, she was having a device. And when I asked her why, she told her because you have any mitral valve collapse or anything. She told me no, to monitor my heart rate, to have the recording of my heart rate. But anything, it might be that I'm a device to monitor her heart rate. But she doesn't have any heart condition.
Yes.
So this is the case. But you did it well, and you got the diagnosis, and you ask about everything. So that's good.
Ask about what?
You ask about everything, and
okay.
You did it well, Dr. Yes.
Thank you, Dr. Sarah. Thank you. Very, very, very nice case, really.
Yes, at least I know people here, they have it. It came.
Yeah, they brought it, by the way, but it's not, it's sporadic one, so it's not common one, but still it can come, and we have to know this unique and very rare cases.
Yes, the issue is starting to bring cases that we are not aware about.
Yeah, they are trying that. I guess they are trying to make bases more difficult to pass since they open the eligibility. And they are not limited the years for passing. So now they are giving you a lot of opportunity to get exams more and more and to pay more and more. Yes. So they make it difficult to pass. This is what I noticed.
Yes.
Even the passing percentage, every diet is very low. I guess they can pass only 1 for 5. So it will be like 20 or 30% pass. in the whole center. Okay. Anyway, the case very nice, and yeah, the distractor thing also here very nice. The fibromyalgia, and it's something occasionally, Dr. Rhoda, because Dr. Rhoda thought there is link between fibromyalgia and the joint mobility or hypermobile joint.
No.
It's not. Don't be distracted. Yes, it's there, but just mention it in the finding
Maybe
and do the examination of it. But it's not related. It's nothing syndromic.
yes, but maybe
Yes, if
fibromyalgia
Marfan, that's why.
syndrome could be related because all of them are functioning, could came together to the same.
Yeah. I mean,
Also, I read it on the NHS. It's written that it could be combined with chronic fatigue syndrome, fibromyalgia.
yeah, it might come in like this.
Because all
Yes,
are
functional disorder. Yeah, that's why when I explained the disease, I said it's a collection of functional disorder, and POTS also one of the functional disorder, and the vasovagal as well. Nothing organic you can explain the disease for. It's just hyperreactivity or dysregulation in the system controlling the things in your body and the nerves. I mean, nerve cables. But it's nothing organic or nothing you can treat by medication. Just lifestyle, as you said, and some lifestyle modification.
Yes.
Yeah. Apart from this, I want to ask, what is the hypermobile joint here?
It's present. I send it on the group. It could be associated with hypermobile joint.
Yeah.
I will check it. I checked and I sent it on the group. This is on
Yeah.
an NHS website.
What?
On the NHS website, it's written it could be, and this patient that I saw, she was having hypermobile joint.
Yeah. What the condition? I mean, is it a what the disease?
No, she told me I have hypermobile joint, but she didn't say hypermobile syndrome.
Yeah. So it's not
no.
Marfan. It's not
No.
pseudoxanthoma elasticum.
And she doesn't have feature of any of these things. No.
But you find these things in her skin and the joint.
Yes, she make for me the wrist sign and the thumb sign, and
yeah, good. Yeah, good to know. And by the way, you can name it, but it's not related.
Yes.
I mean to the case. If the examiner asked you, you can say there is finding indirect related to the condition, or it's not related because again, it's not related. Just to distract you and to think what's the relation, and you might be stressed for that. It could be related, but I mean it's not indirect related or something occasionally associated, but it's not the underlying cause of the condition.
Yes.
Okay, so don't overwhelm your thinking. What is the relation? What's the link? What? Just mention it to the examiner and tell him I am not sure is it related or not. And please, whenever you have positive finding, you have to examine everything. So Dr. Sarah remind me when I said I will examine the joint, she said, yes, there is joint hypermobility. I went back to the hand, I examined these things. Again, the examiner focusing in small things like this. If you didn't examine the joint, they will comment on that. If you didn't examine the skin, they will comment on that. Although the case is not related to this, they minus me in the charcot joint because I didn't do abdominal examination, which is not related to the complaint. But what I want to say, the examiner being much tough nowadays, and they want to minus you for small things. Maybe you can say idiot thing or a stupid thing like the examiner. Really, they are becoming very stupid things. They are minusing you on it, and you will feel very upset for that reason. But what to do? We have to face that, and we have to battle this war. We are in war with the examiner. We have to win it by any way. You have to focus about every small thing in the finding or in the history. You have positive history, you have to do it in the examination. He has abdominal pain, you have to act like you did abdominal examination. You will not find anything, just to show him I did the abdominal examination because he has abdominal pain. He will be satisfied for that. Although he will look for you very stupid, but it's okay. What to do? We have to pass. Okay. Sorry to say this, but this is the real. Really, this is what's happening nowadays.
Only Dr. Basim, I forget, you can also say we'd like to do for her ECG. I didn't hear this or heart rate.
Yes, you're right. Yes. Oh, and even you can arrange Holter
Yes, that's why I'm thinking.
to find the arrhythmia, yes, which is, it will be sinus tachycardia. However, you can just say it. One
Yes.
of the tools to diagnose the condition, because it happened while patient standing. It might happen while and at home, but it might be also it might not be at the clinic. But again, table test will diagnose it, because changing the position will give the trigger to find out the arrhythmia or the tachycardia. So it will be positive when you do this test, table test. The same test will diagnose vasovagal, because what will be the reaction? It will be bradycardia and hypotension. Here it will be tachycardia, hypotension.
Yes.
Okay. Dr. Roda also mentioned anemia. Yes, I agree 100% to mention anemia for any dizziness. And always I'm reminding you and reminding myself now, I should ask about anemia. Anyone told you are paler than before? However, I examine the jaundice and pallor. But again, you have to specify history about anemia. Any dizziness, put anemia, please, in your differential. It might be anemia and you are roaming around the causes, and it will be anemia. Okay. Thank you, Dr. Roda, for this. And thank you, Dr. Sarah, for the case. Someone was talking. Sorry, I interrupted you. You can talk now, please. Dr. Azhar?
Dr. Vasam, just
Yes,
I
sure.
want to add some triggers. This sports is more around the at the time of periods,
Yeah,
more in the morning, hot weather, and standing for long time.
yeah,
And regarding the treatment, we can if we systematically we will not forget fluids. We will give 3 liters fluids and
yeah,
increase amount of salt. Then
yes,
we have to avoid the triggers,
yes.
compression stocks, and
Excellent. Yes,
aerobic exercises. Then for
yes,
the pharmacological treatment, beta blockers, midodrine, and flutocortisone, as Dr. Sara mentioned.
yes,
Uh,
exactly.
so mainly in the tilt table test only there will be tachycardia and the blood
Yes.
will remain normal. There will be no hypertension,
No hypotension, only tachycardia. Yes.
only tachycardia.
And this tachycardia lead to the syncope or feeling dizzy
Yes,
because
yes,
of the
yes.
tachycardia, but not no
Uh,
hypotension.
and there is a exact figure of 30. There is increase in the pulse rate of 30. For example, you have pulse 100, it will be more than 130.
130. Yeah,
It is the figure of 30.
yeah,
It will rise more than 30.
yes, yes.
But our this case was very nice case.
Yeah, very nice case. Thank you, Dr. Azhar, for your comment. Yeah, Dr. Roda, share a circle. Very nice. What's symptoms? Lightheadedness, eating disorder, weakness, brain fog, blurred vision, tremors, exercise intolerance, fatigue, gastrointestinal distress. Gastropathy, yeah, the comorbidity, autoimmune disease, MCAS, mixed connective tissue, I guess, mixed connective tissue, fibromyalgia, iron deficiency anemia, migraines, EDS, and hypermobility. Yes, it's here. MEI, chronic fatigue syndrome, ME, chronic fatigue syndrome, I guess also fibromyalgia, celiac disease, irritable bowel syndrome, gastroparesis. Yeah, nice. Okay, you can share it to the group, Dr. Roda. Thank you so much. Yeah, again, I repeat this advice. Since the patient was having fibromyalgia, you have to examine for the tender point. It's not related, I know, but again, they might put for you a comment, he didn't examine for fibromyalgia. This is the way how they are judging and evaluating the candidate. I remember just now when I read chronic fatigue syndrome. So sometimes you have positive finding and symptoms, you have to examine them, and plus the pathognomonic finding, you have to examine what you should examine, plus the thing you have it in the history. Let's say, for example, in this patient is having fibromyalgia and irritable bowel syndrome. And the positive finding or the positive thing you will have in the examination, the tachycardia. So you'll examine the heart, the tachycardia, the pulse. Then don't miss the fibromyalgia examination. It's just pointing to the muscles. Any muscle pain, any pain here, let me know. Irritable bowel syndrome, so you have to do abdominal examination, very quick examination. Then just the other examination to complete the examination. Plus also, of course, the joint hypermobility. This is the advice for the examination, how to examine or what to do in the examination. But if you have thyroid disease, for example, you have to do the steps of thyroid. But if you don't, like this patient, you have to do the positive finding in the history, either past medical history or sometimes even the scars. If the patient mentioned to you, I have pacemaker, you have to examine the scar for pacemaker and the area of pacemaker. Even it's not related, or it will be indirectly related. For example, arrhythmia, patient presented with dizziness, and you will do examination of the heart. It might be pacemaker related, so you have to examine the pacemaker site and the scar site for the pacemaker. Okay, try to be optimized in your examination and the analysis of the history and the complaint. This is the take-home message. Any question or comment about this case or the previous scenario? Any question, any comments? Any added comment? Yeah, Dr. Ayan, amazing sitting. Thank you so much. Thank you. Thank you, Dr. Roda, also for your shares. Appeared before Dr. Ahmed Mandoor asked, appeared before, I guess it was before with the old format. I guess so. But in the new format, I didn't hear. But again, you don't know what they are thinking. They might bring it in the future, and it might came in some different centers. You don't know about their cases. You have every week, I guess, or every 2 weeks exam in different center, and you don't know about these centers. So you don't know, and we are not aware about all centers and all
But
cases.
it's good. I know one that she had it last year.
Last year, yes, this is what I mean, because
Yes.
sometimes it will be not shared by others. Maybe it came to this group, but they didn't share it, or this center, and no one share it. Maybe, you know, occasionally your friend or your colleague, and she will tell you this case came and you will give it to us.
Yes.
Yeah. Anyway, thank you, Dr. Very nice case. Informative session. Why not Addison, Dr. Mahmoud Musa? Why not Addison? Yes, it's one valid, but what other also positive in the Addison? You have to have the diarrhea. Hypoglycemia, sorry?
The blood pressure below, not heart rate.
Yeah, low blood pressure, diarrhea, association with other autoimmune. The Addison will present itself by itself. Don't worry. If you find Addison, it will be Addison. You will find another finding of Addison. Autoimmune polyglandular.
Most important is weight loss. Weight loss.
Weight loss, exactly. Weight
And
loss,
diarrhea will be
hypotension,
malabsorptive.
hypoglycemia.
And diarrhea will be malabsorptive diarrhea, greasy, pale, bulky, offensive, difficult to flush away. Diarrhea.
Are you sure? I guess diarrhea of Addison is not malabsorption. It's
Due to celiac, he might have celiac.
watery. If celiac is there, but Addison diarrhea itself watery, not malabsorptive diarrhea, Dr. Azhar.
Yes.
You can recheck. I have checked it many times.
Yeah. No, yeah, I guess it's if celiac associated, it will be malabsorbed. But if not celiac, it will be watery diarrhea, steroid responsive. So whenever
Yes.
the patient takes steroid, it will be improved. So it's watery diarrhea, yes. And also the pigmentation in the creases, pigmentation in the hand, in the mouth, buccal cavity. Addison will present as Addison. Everyone will know Addison from the presentation. But this case was weird, and yeah, as Dr. Sarah said, it's very rare, but it happened. Okay. Addison, also don't forget the autoimmune polyglandular syndrome. It will be as Addison type 2. So you will have thyroid disease and also diabetes. And it will be presented with diabetes in the past medical history. But nice to mention it and nice to think about it. Okay, any other question? Any more comments? Epilepsy also I should ask about, but I guess it's not epilepsy, since she said I didn't lose my awareness, so I rule it out. Whenever I will have loss of awareness, I will think about epilepsy, hypoglycemia, even syncopal attack, but she said I never lost my awareness. That's why I didn't think about epilepsy and other causes of loss of consciousness. Okay, nice comments, nice sharing, nice ideas. Thank you, all of you. And thank you again, Dr. Sarah, for the case and the practice with me. Any question before ending the session? Any suggestion? Okay, thank you. We'll see you tomorrow, inshallah, with another day, clinical or communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.